All right. Thanks for switching over and being flexible with the switch. I'll send an email tonight after class with the new class link. And I'm gonna write myself a reminder. We just have to switch Zoom accounts. Okay, so tonight will be our poisoning and OD, bleeding and shock, and our behavioral and psych emergencies. So that's going to be what's on the docket today. We'll see how long that takes us because we got 3 lectures, which it should be pretty short. So again, if you guys have any questions, you can ask me in the chat or you can unmute yourself and ask, okay? So we're just gonna kind of jump into this. I hope everybody's Saturday skills went well and that you guys are going over some good stuff. Okay, so stop. I'm gonna go ahead and share screen here. Okay, so today we'll start with our toxicology lecture. Toxicology, we'll be going over poisonings and ODs of our patients. So we'll talk about different drugs. And so this is from our book doing our lecture here. So we'll go over things such as carbon monoxide poisoning, which we have gone over in the past with our respiratory type emergencies, but we'll kind of touch on it again because it does count as being toxic to your system, right? We'll also go over nerve agent poisoning and then how and when to contact poison control. When we're going over our medications and talking about activated charcoal, also using poison control as a resource to see if things such as activated charcoal will help for whatever poison that they've ingested, right? So we'll go over inhaled poison, ingested poisons, injected poisons, absorbed, and then we'll also touch on alcohol and withdrawal. So each day we come into contact with things that are potentially poisonous to us. Acute poisoning affects 5 million people each year. So definitely things can be toxic to us, even things such as medications and different substances. So sometimes even, well, we'll go over medications as well, but medications mostly have a therapeutic level. That's why you have a suggested dosage, right, of the medication, because that brings it to its the level that's acceptable in your body to have that medication do its job. But if you take too much, then you can get into that toxic level to where it just does not the opposite effect, but it does detriment to your body. So we'll talk about that too. Chronic poisoning is much more common. So chronic being over the long term, caused by abuse of medications, tobacco, alcohol, and drugs. So that consistent usage. Deaths caused by poisonings are fairly rare. They've decreased steadily since the 60s due to safety caps. However, deaths caused by poisoning in adults have been rising as a result of drug abuse. Let's see, I'm gonna get other people in our, okay. So rising drug abuse kind of deaths are what we're seeing. Toxicology is the study of toxic or poisonous substances. So poison is any substance whose chemical action can damage the body structure or impair bodily function. And then substance abuse is a misuse of any of those substances to produce a desired effect. So usually, right, that effect is some sort of euphoria or numbness or something. And then an overdose is that toxic dose of the drug. So like we talked about, we have therapeutic doses of drugs, and then if you have more of it, then it's that toxic dose. So the primary responsibility of us is recognition for our patients. Hold on. Yeah. Other students not getting our new link. Okay. So very small amounts of some poisons can cause considerable death or damage. So sometimes the toxic dose of some substances is very minuscule and sometimes it's a lot, right? So it's the difference of somebody overdosing on fentanyl, which can have a very little amount of that to overdose, versus like ibuprofen, you need a bunch of pills to overdose on that, right? So kind of that difference depending on the substance. If you suspect poisoning, notify medical control and begin emergency treatment. So medical control as well as poison control is a good tool to utilize. So the signs and symptoms of poisoning vary, right? Because it depends on what substance that our patients have overdosed on, right? The effects of a fentanyl overdose versus an Advil PM overdose are going to be varying. And sometimes we know what our patients took, sometimes we don't. Sometimes they have mixed multiples, and so it'll be hard to tell. Okay, so we, for example, have different agents listed here. So opioids and what they do, so different signs and symptoms. So if somebody is ODing on heroin or oxycodone, you're going to see different signs and symptoms. So you're going to have hypoventilation or respiratory arrest because those opioids depress that respiratory system. They're going to have pinpoint pupils. So we talked about having our pupils and how we want them to react. We want them to be pearl, so they'd be equal, round, and reactive to light. But with opioid overdoses, you're just going to have those constricted pinpoint pupils. And so when you introduce light into their eyes and nothing happens, right, then we're thinking about the potential for opioids on board, right? And even if our patients haven't OD'd on opioids, even if they're just taking prescription drugs like they're supposed to, if they're prescribed them, you can still have these signs that you'll be able to see. Then we have different substances like sympathomimetics. So these are going to be epinephrine, albuterol, cocaine, methamphetamines. And so these are going to be stimulants. And so with our opioids, you have pinpoint pupils, sedation, hypotension, right? And you can have more of those downer types. You can see the downer type medications on the sedatives and hypnotics as well. But with the sympathomimetics, you have hypertension, tachycardia, right? So high blood pressure, high pulse rate. You have the dilated pupils, right? So instead of pinpoint, they're open and dilated. You can have agitated patients as well as patients that can have seizures. So a lot of times with these stimulants, it kind of overtaxes the brain, and your brain kind of has this freak out, and because it's trying to make too many connections at once, and you can have a patient that seizes. You can also have hyperthermia. So hypothermia, right? High and low. So with those stimulants, you can have patients that get too hot. These sedative and hypnotics like diazepam or Valium, Rohypnol, these types of drugs, then you're going to see these slurred speeches, sedation, right? Hypoventilation, hypotension. So these are going to slow stuff down. Anticholinergics. So anticholinergics and cholinergics we'll go over a little bit more in depth. But these anticholinergics like atropine or Jimson weed, which is a plant, but also can be used as a herbal remedy of sorts. You can see when you overdose on these, tachycardia, right? So high heart rate, hyperthermia, overheating, hypertension, high pressure, dilated pupils, dry skin, sedation, agitation, seizures, coma, or delirium, right? So you can have kind of that spectrum, and then decreased bowel sounds. Another example of the anticholinergics, which I've seen more often, would be like Benadryl. So patients that overdose on Benadryl, or I've had a couple patients that overdosed on like Advil PM because they have Benadryl in there in those types of medications. So you can see patients kind of out of it, hallucinating type stuff. So Benadryl overdose is what I've seen with these anticholinergics. And you can see a lot of that. And we'll go over a mnemonic for it as well. Is it a mnemonic? Or I can't remember what it's called. But on how to tell the difference between cholinergic and anticholinergic. So cholinergic will be like the nerve gases as well as like rat poisons and things that, what are those called? That they get sprayed on crops and stuff. So crop dusted type chemicals. So on the opposite of these, right, cholinergic, on the opposite of anticholinergics, being cholinergics, you're going to get excess mucus, defecation, urination. So they're just going to be like sweaty, gross, salivating all over, because this has more of that effect versus like the Benadryl overdose has more of a drying and heating effect. So with cholinergics, pinpoint pupils, excess lacrimation, so tearing up or salivating, airway compromise, and then nausea and vomiting as well. So you kind of have those two distinct type of poisonings, and their signs and symptoms are completely opposite. So if possible, what do we ask? What can we ask, right? So we can ask our patient, depending on how altered they are, what did they take, right? Did they take pills? Did they drink bleach? We kind of want to know. When did they take it or become exposed to it? So again, it could be a poisoning that was intentional or accidental, right? So when were they exposed? When did they take it? When did they think they were exposed to it? Type questions. How much did they ingest if they know, and what actions have been taken, and then how much do they weigh? So why do you think asking somebody how much they weigh could be an important piece of information for us to know?
To know the proper dosage.
Yeah, absolutely. So if we're doing like activated charcoal, right, knowing how much our patient weighs to be able to give them an accurate dose for what we need to give them. On kind of these same lines here, how much do they ingest, right? If it's a pill bottle, if we have the pill bottle, we'll take the pill bottle with us to the hospital type stuff. If they don't know if they took everything in the bottle, right, we have the bottle for the hospital and they'll treat it as they've taken the entire amount, whether we know they did or not. We just kind of go big, right? We want to try to determine the nature of the poison. So we want to look around for clues. So if we can get our patients to tell us what they take, great. If not, look around. Are there empty pill bottles places? Are there needles and syringes? And we can kind of look around and see what we can see. If there's any suspicious materials, potentially taking it with you so that it can be analyzed at the hospital, um, and they can go from there. And then containers at the scene could provide that critical information, right? Especially if your patient doesn't know what they took or they're altered and can't really tell you. If your patient vomits, you can look in there, look in the vomit. Sometimes if we can catch it, our patients can vomit in the emesis bags. So the bags that we have in the ambulance, and then those contents can be examined at the hospital, right? So seeing if there's pill fragments or anything of that nature in there to see if it has been expelled from the body. Whew, sorry. Another thing too would be so one of the questions was, what have you done, right? Have they tried to induce vomiting? Have they taken charcoal themselves? We want to know about what interventions they've tried before we got there too. So how do poisons get in the body? We talked about different routes. The most important treatment we can perform is diluting or removing that poisonous agent, right? So some poisons have an antidote. Most of the ones we're going to encounter don't have an absolute antidote. So pretty much diluting is going to be our goal, because we can't like pump stomachs or anything. That's going to have to be done at the hospital. But either we're going to be able to give our patients that activated charcoal, and that charcoal like coats the stomach and the intestine lining, so that way there's no more absorption. Or we're having ALS on scene, right? And we can probably give them IVs for diluting any agent. But poison control is going to be a really big help for us to determine what we can and can't do, right, for treatment of our patient. So different ways are inhalants, powders, pills, or injections, right? So inhalants, getting the patient out of that environment or away from that container. So whether it's rubber cement, a lot of calls that I've been on or heard of, especially in the borough, are inhaling gas fumes, or doing the what is it called? That compressed air, right? To like that air that's in a can that you blow off electronics with. So people doing whippets off of those. Those are going to be the inhalants that those poisons and how they get introduced into the system. Could be a powder. If we do have a powder, brushing the powder off, all the dry powder off as much as we can before wetting it down. Sometimes the powdered chemicals react with water, so we want to get as much of that chemical off before introducing water. And then pills, right? So with pills, our course of action is usually charcoal, right? To coat that stomach lining and coat the intestines. So that way that absorption is slowed down or stopped. And then injection, there's not really a whole lot we can do about injections because it's already completely in the bloodstream, right? So, but recognizing that that is the entry location could be helpful for us to determine. So all routes can be deadly. So each are going to be thought of as equally serious, depending on which route that this poison was introduced, we can kind of have a variable timeline, right? Because with injections, it's going to be a lot faster of a reaction to their body versus like pills, because it takes time to break them down and absorb them into the body. But depending on what substance, right, everything we're acting as, it's potentially deadly for our patients, right? And overdosing is considered a high priority patient. Okay. Always contact medical control before you proceed with treatment, because there are so many different types of chemicals and poisons that our patients can get their hands on. It's hard for us to kind of keep all of those medications kind of straight. So if we contact medical control and get medical direction to potentially see if there's anything that we can give them to slow down the progression, or if there's something that we absolutely should not give that maybe counteracts, or if we give it, can kind of make things worse. So that's where poison control or medical control comes in handy. So we want, with those inhalants, like we talked about, whether it's huffing gas, whether it's carbon monoxide, right, moving them to fresh air immediately. So moving our patient to fresh air, and especially if they're in an enclosed area, making sure we move them to fresh air. So that's where we're operating, is in fresh air, not in that environment with those substances. So things such as, right, if they're in an enclosed space with gas, getting out of that area. Okay. Patient may require supplemental oxygen, so getting a non-rebreather on them. And then if we have to go in and retrieve a patient, right, we or fire department personnel or whatever, using a self-contained breathing apparatus to protect us from those fumes. So scene safety, right? We're making sure the scene is safe for us to even approach or be in. So examples such as that, if there's too high carbon monoxide levels in there, ventilating the area, or getting responders in there with an SCBA to bring the patients outside. So don't compromise your own safety. Some patients may need decontamination after removal from a toxic environment. So depending on what they've been exposed to, they might need to get deconned. At the hospital, if you've ever been at the hospital, they do have a little decon shower unit just off the side of the ambulance bay. So if you do have your patient that needs to go through that decontamination shower, they'll go through that little side entry, go through that decon shower, get rinsed and scrubbed off before they're allowed in the ER, because you don't want any of that substance to be brought inside to the ER, right? And then you'll clean out your ambulance pretty good. All patients who have inhaled poisons are required immediate transport, right? Because we're not sure what damage that it's caused or is still doing to the airway. So any kind of inhaled substance we're treating as a high priority patient. If there's any containers, bottles, labels like that, take it with you to the hospital so that way it can be looked at and analyzed. And as well as making sure that we put it in our report that it was there on scene. Stop. Dogs. So patients sometimes attempt to commit suicide in a vehicle with inhalants, and that's something we want to be aware of. If they put exhaust fumes inside their vehicle, so sometimes they try to have a hose from the tailpipe into the vehicle to commit suicide with the carbon monoxide fumes and those exhaust fumes. If you open the door, you get like that concentrated exhaust from that inside of the vehicle to wherever you open that door. So being careful that you're not exposing yourself to those toxic fumes as well. We could consider contacting the borough hazmat team. So if they do have this carbon monoxide buildup of like those tailpipe fumes in their vehicle, or even if they've tried to commit suicide with like different chemicals. So sometimes they mix like bleach and ammonia, right, to create these caustic chemical vapors. So we don't want to open doors or break windows or anything to release that out into where we can be exposed to it. So hazmat team might be something that we can call. Oops, sorry. Okay. And then so we can get poisons that are absorbed through surface contact. It can affect patients in different ways. So they can get skin damage right from the contact, chemical burns, rashes, and then full systemic effects like wet with depending on how much of that poison has been absorbed into their skin. So it's going to be important to distinguish between contact burns and contact absorption. Sometimes it'll be hard to tell, but sometimes these chemicals that get spilled on somebody or the powders or whatever can just burn that skin versus they've had it and the skin's absorbed it. So, and it really does depend on what chemical it is too. So if we can determine what chemical it is, it'll be a lot more helpful. So signs and symptoms, a history of exposure, right? So they know what they've been exposed to. If there's any liquid or powder on the patient's skin, if with contact it burns, itches, has any irritation, or has any odor of a substance that's on them. We want to avoid contaminating ourselves or others, right? So we're going to want to consider using our PPE as necessary. We also want to remove substances from the patient as rapidly as possible. So we talked about if it was a dry powder, brushing off as much of the powder as we can before wiping them down or essentially hosing them off, right? And then remove all contaminated clothing. So because clothing can hold on to all these different types of chemicals, whether it's a powder or a liquid or whatever, making sure that we remove that clothing, bag it up, and then flush and wash the skin. So that way we can stop whatever contact absorption or if it is burning, right? So getting off as much of it as you can, including clothes, and then rinsing and decontaminating. If they've got it in their eyes, and we want to flush their eyes out, right? So this is an example of a nasal cannula, right? So the oxygen tubing that goes into their nose, it's been used as an irrigation. So they just hook up an IV bag onto the end of that nasal cannula, and you can place it over the bridge of the nose and have that continuous stream of saline flowing, so that way you can flush anything out of their eyes. So it depends if the substance is in one eye or both eyes, right? This one's obviously flushing both eyes. You can take like saline is usually what we use because we have a lot of it, whether it's IV bags or irrigation solution or whatever, and flush the eyes. You can just use water if that's what you have too. If you have one eye that's compromised and not the other, when you flush out the one eye, make sure that one's the one aimed lower, right? Because if you flush from top down with that gravity, you're going to have that that water or that saline flow down. So if this is the affected eye and you're flushing it out this way, now you have both affected eyes. So if this is the affected eye, making sure this one's turned down so that way you flush it away from that unaffected eye. Kind of the rules are 5 to 10 minutes for acidic substances, 15 to 20 for alkaline substances. Sometimes we can't really tell, so we're just continually flushing for up to 20 minutes. And we just want to make sure we get that as much out of there as we possibly can. Another thing too with substances in the eyes, making sure our patients, if they're wearing contacts, getting those contacts out, because the contacts can trap chemicals behind it and actually like kind of seal them to the eye. So I've had a patient that had gas splashed in his eye, and he rinsed out his eyes really well, except he never took his contact out. And so that night he fell asleep with his contacts in, woke up in the morning, swollen eye, bloodshot, in so much pain, couldn't even open his eye. And that's because that gasoline was trapped behind that contact and started pitting in his eye. So it started like wearing down at his cornea because of how corrosive gas is. So being careful of making sure to take out any contacts if there are any. Wash off substance immediately. So especially in industrial settings, they'll have MSDS or should have MSDS sheets that tell you what the chemical is and first aid actions for said chemicals. So if they have those material safety data sheets, utilizing them to see what kind of first aid action is necessary. So the only time we don't want to irrigate with water is if the poison reacts violently with water. So again, if we don't know what chemical substance is on our patient, then that's going to be a hard one to determine. But if we do know, right, and have those MSDS sheets, we want to brush that chemical off as much as we can, remove that contaminated clothing per our usual protocols, and then we're just going to apply dry dressings to the area instead of rinsing it off and flushing it. If we had patients that ingested poisoning, so about 80% of poisonings are going to be ingested, so taken by mouth. So any drugs, liquids, cleaners, contaminated food, or plants, about 80% of our calls for poisons are going to be ingested. So in kids, it's usually accidental. With adults, it's usually deliberate. Signs and symptoms will vary with whatever was ingested, right? What type of poison, how old the patient is, and how much time has elapsed since whatever it is has been ingested. Can you hey! Sorry. Dogs. So goal is to rapidly remove as much poison as possible from the GI tract. And so what's going to need to happen is that our patient's stomach gets pumped, essentially. But we don't have that as an option. So what we need to do is get them to the hospital ASAP. And so a long time ago, syrup of Ipecac was utilized by EMS. It is no longer. And some of the main reasons is we don't want to induce vomiting in our patient, whether we use syrup of Ipecac to do so, or if our patient tries to induce vomiting themselves. We usually don't want to do that because not knowing the chemical or chemical components, we don't really want it to come back up and do more damage, right? It's already done damage on the way down. Don't really want to have it do more damage on the way up if we don't know what it is. And things like pills and such, it's not going to be as much of a problem having it kind of thrown up, but things such as bleach or Drano or whatever, something caustic that they've ingested, if they throw it back up, right, you're doing even more damage to your essentially esophagus and mouth. And so if we can avoid that, the better. So we've used activated charcoal for a number of years now. I wouldn't say it's utilized super heavily. A lot of the times we just get our patients to the hospital and get their stomach pumped. But with pills that patients have taken, this can be utilized and can be pretty helpful. Like we talked about, it coats the stomach lining and the GI tract. And because of that charcoal, it absorbs some of those toxins and binds to them. So that way they don't get absorbed even more into the system. So there are these different types of activated charcoal, usually in a suspension. Because it's activated charcoal, that's what absorbs a lot of those toxins and kind of carries them out of the system and helps with the stomach being pumped and things of that nature. Then we have injected poisons. So usually the result of drug abuse, right? Such as heroin or cocaine, something of that nature. Signs and symptoms are weakness, dizziness, fever, chills, unresponsiveness, or excitability. So with these type of injected drugs, you can see different signs and symptoms. And depending on how much they've taken and what their tolerance level is. So injected poisons, it's already kind of too late, right? It's already directly into their bloodstream. Giving them things like activated charcoal is not going to do anything. It's absorbed super fast. And because usually these injected drugs are not a really good chemical compound to be injected, can cause local tissue destruction. A lot of times they'll collapse veins and do some nasty stuff to those injection sites. And a lot of the times they get infected as well. With any injected poisons, we want to monitor the airway, give high flow oxygen, and be alert for nausea and vomiting, and then transport as quickly as we can. So being alert for nausea and vomiting, right, we have suction ready, as well as, if we can, having our patient placed on their side in case they do throw up. They're not laying on their back and don't aspirate. So going through our assessment, right, our same kind of medical assessment. We're going through a size up, our primary, a history taking, secondary, and reassessment. With scene safety, we want to determine the safety. So if there is the chemicals like carbon monoxide, right, is an inhalant type poison, we want to get out of that environment and into a cleaner air environment. So we want to determine the number of patients, the need for additional resources, and then is this a medical, is this a trauma, is this both? Do we need to consider C-spine? And then the appropriate PPE as well. So mechanism of injury or nature of illness, right? You may get the information during dispatch, or it might be an unknown from dispatch, and we need to figure that out. If we're not sure, we're going to look for clues when we're doing our scene size up. So are there any medication bottles? Are there any alcoholic beverage containers, syringes, drug paraphernalia? Is there a odor? Can you smell anything? And do you see anything suggesting a drug lab, right? So anything that could indicate maybe a meth lab or that they're making their own drugs. We're getting our general impression, so level of consciousness, right? When we want a baseline level of consciousness because we want to know if they trend better or if they're deteriorating. We want to determine any life threats, so any compromise with their A, B, or C. And don't be fooled into thinking that a conscious, alert, and oriented patient is stable, right? That's why we're doing our baseline and getting reassessing and comparing it to our baseline, because patients that have been exposed to poisons like this, especially injected poisons, right, can deteriorate very quickly. Airway, breathing, and circulation. So make sure they have an open airway and adequate ventilation. Don't hesitate on oxygen therapy. Just go ahead, give high flow O2 to these patients. We want to assess their circulatory status, their pulse, and their skin condition, right? We want to make sure they're circulating appropriately. And then transport. Are these high priority patients? For the most part, absolutely, right? Usually we don't really want to delay our transport time and stay on scene. So as soon as we can transport them, we're transporting. We can do our scene size up and primary assessment on scene, but we can load them up and go and do our secondary assessment on the ambulance. Consider decontamination depending on what they've been exposed to. That's when, poison control can be a help on that as well. But if you can't decon them before they get in your ambulance, making sure you decon them through that little side door at the ER and then bringing them into the hospital, then you're going to need to decon your ambulance. You're going to do it anyway, but decon it from that substance and then making sure you guys have a clean uniform as well, or change of clothes. And then in the air transport considerations, decontamination is important, especially with the rotor wash helicopter, if it's any sort of powdered substance, powdered poison. History taking. So what is their chief complaint? Why were you called there? If they're responsive, see if you can get your sample history. If they're unresponsive, see if you can get a history from friends, family, bystanders. Are they wearing any medical alert jewelry? Right? Anything that can indicate what might be going on if we don't know. Ask what substance was involved, when did the patient become exposed to it, and at what level of exposure. So these will be important questions. And then over what period did the patient take the substance, right? What did they take, just a bunch of it at once? Did they just take more throughout the day? And then has anybody done any interventions? And then again, patient weight to determine if we do need to give them like activated charcoal. Okay. Before we move on to secondary, it is 6:50. So let's take a 10-minute break here and come back at 7. All right. So as we're going through our secondary assessment with patients that have suspected poisoning, we want to focus on the area of the body involved with the poisoning or the route of exposure. So if it was a contact poison, right, if there was something that they had touched and it burned their hand, focus in on that. If it was an injected poison, right, it'll be more systemic. And we're going to be focusing on the treating their signs and symptoms as we can, right? So if it's difficulty breathing, we're doing that. So things that we can intervene on. Vital signs. So many poisons produce no outward indications of the exposure's seriousness. And a lot of the times, right, we get those signs and symptoms that we can kind of piece together, put those pieces of the puzzle together that tell us it could be a poisoning. But we're looking for that altered level of consciousness, right? Pulse, respirations, changes in blood pressure, and then their skin. We want to reassess the adequacy of their ABCs. So when we did our primary, we had an airway or opened it, they're breathing or we're assisting it, and they have, they're circulating or we're doing compressions. But when we reassess them, right, how is that, how are they holding up? Do we now need to intervene when we didn't have to before? And then right every 5 or every 15 minutes, depending on the stability of our patients. And then the interventions. So those interventions that are supporting our ABCs, like our oxygen therapy, BVMs, things like that, those are going to be the utmost important. To dilute airborne exposures with oxygen. So if they were inhaled poisons, our job is that dilution, right? So more oxygenation to hopefully dilute that, that chemical exposure. Remove any contact exposure with water, so we'll flush it out. Activated charcoal for ingestions, and then contact medical control or poison control for treatment options. And then communication and documentation, right? It's going to be vital. So report as much information about the poison as possible. Again, if there's any containers or vials, bringing those with us. If they have an MSDS sheet, if it's at a workplace or something, bringing that too. So ensuring scene safety, follow standard precautions, make sure PPE, and then doing a decontamination. So we're deconning our equipment that we've used. We're deconning the ambulance that we transported them in. We might need to change our clothes and our uniform if we have the potential to be exposed as well. So keeping those in mind. If your patient's unconscious and they have tablets or fragments or whatever in their mouth, removing those, and then washing or brushing the poisons off. We're assessing and maintaining their ABCs and reassessing, which will be vital, especially if we don't know what they've been exposed to. Oxygen and ventilations, and then considering the activated charcoal. So with activated charcoal, we've talked about it going over pharmacology, but those who have ingested an acid or an alkali, a base, or a petroleum product, activated charcoal is not going to be indicated. So because that activated charcoal will mix with any sort of liquid substance, it's not going to do its job of that absorption and that coating, right? Also, if they have a decreased level of consciousness and they can't protect their own airway, then we're not giving them charcoal, right? If they can't swallow and they might aspirate it, we're not giving it. Most of our activated charcoal is a pre-mixed suspension of 50 grams of charcoal. They have different names: Instatur, Actidose, Liquid Char, whatever, it's all the same stuff, just a different name. So 1 gram per kilogram is going to be that usual dosage. And then it really is up to 100 grams, so up to the 2 bottles of the 50-gram solution. So before we give it, contacting poison control or medical control, making sure that if we give it, it'll actually be useful. Because it is kind of a black tarry substance, they do have sugar in them to try to sweeten it for people to drink, but it really doesn't matter. So we need to inform our patient as to why that they need to drink it. And then it might take some persuasion, right? Because it's not a fun thing to drink. The side effect, they're gonna poop black, of course, because they're drinking activated charcoal and it's coating their intestines. So it's how it's gonna look. If the patient has taken a poison that they're nauseous and vomiting already, if they take the charcoal and vomit it up, may have to repeat the dose of activated charcoal. So being aware of that. But if they do keep throwing it up, maybe ceasing that treatment option and just foregoing that to transporting them to the hospital instead, as well. So then specific poisons over a period of time, if they routinely misuse the substance, they may need increased amounts of it. So they're building up a tolerance. So usually patients who get addicted to pain pills, right? They have to have more and more pills. Then they start going more into dabbling with injections. And then they need more and more of the substance to do what it used to do. Most substances can be abused, so being aware that might be the potential as well. The importance of safety awareness and standard precautions cannot be stressed enough. So known drug abusers have high instances of serious undiagnosed infections. So because they have to get access to drugs illegally, usually it's not the cleanest environment, and they do have the potential, if they share needles or things of that nature, getting HIV, getting hepatitis. So being aware that chronic drug users are not usually the cleanest of patients, so being aware of that too. All right. So, and then alcohol intoxication counts as a poison, right? So use and misuse and abuse of alcohol. Most commonly abused drug in the US, kills more than 200,000 people each year, and is one of the greatest national health problems. So being aware of alcohol intoxication and how it affects people, and then the long-term effects of chronic alcohol abuse. So with chronic alcohol abuse, the most common effect is liver damage. What happens is the alcohol over time breaks down the liver and starts to harden it. And the liver is that filtration organ, and so it's like a sponge. But as more alcohol goes through it, and usually in large amounts and time after time, it starts breaking down the liver and leads to cirrhosis. And cirrhosis is that hardening of that sponge, right, that liver. So it's no longer effective in filtering out toxins anymore, and now you have a buildup of toxins that your body can't metabolize anymore. And so 90% of heavy drinkers will develop some level of hepatitis because hepatitis is the infection of the liver. So because it's a breakdown of the liver over time, they get hepatitis, and then which could lead to cirrhosis. Alcohol is a powerful CNS depressant, so central nervous system depressant, right? So affects the brain. Decreases activity and excitement, so it is considered a depressant. It induces sleep as well, dulls the sense of awareness, slows reflexes, and reduces reaction times. So definitely slows things down, reaction times, speech, all of those types of impairments. Some patients, it can cause aggression and inappropriate behavior, and then a lack of coordination as well, since their senses get dulled down. And then also, well, especially with us as EMS being involved, being aware that alcohol is commonly not the only drug that's been taken. So making sure you take that into account, that even though there's alcohol on board, the potential of them having another drug or poison involved could be a potential. If a patient exhibits signs of serious CNS depression, we might need to provide respiratory support. So may cause vomiting as well. So being aware of our patient vomiting could lead to aspiration, right? Throwing up and inhaling that back into their lungs. That's a no good, very bad thing. So being aware of that. And then patients may experience frightening hallucinations or delirium tremens. So patients can be altered, but as well as being altered, can experience hallucinations or be delirious. So being aware of, well, to really expect the unexpected from altered patients. DTs, so delirium tremens, characterized by agitation or restlessness, fever, sweating, tremors, so kind of like the shaking, confusion or disorientation, delusions and or hallucinations, and even seizures. So patients that are under the influence can start seizing on you. And as well as patients that are withdrawing from alcohol, so they're used to having a elevated alcohol level, and then they start sobering up, or chronic alcohol abusers start sobering up, they could get delirium tremens and seizures as well. So might be the alcohol abuse, or because they've abused it for so long, the withdrawals from it can cause this as well. And then opioids. So we have many different common opioid drugs. Codeine's an example of what I've seen patients on before. Heroin, Vicodin, Dilaudid, right? There's a bunch of these different types of drugs that can be seen here. Opioids are named for the opium and poppy seeds. So they're all, that's kind of the base of these opioid drugs. You can have drugs that are synthetic or from the poppy seed in general. But things such as heroin, codeine, and morphine are all derivatives of these opioids. Many addicts have started using opioids with appropriate medical prescription. So a lot of the times it starts with some sort of some sort of pain prescription, right, from their doctor or dentist, and then they either do not get that issue resolved and they need more medication to help with the pain instead of kind of weaning off of it, and then it kind of escalates from there. These are CNS depressants, and because they are depressants of the CNS, right, so that brain, spinal cord, respiratory depression and respiratory arrest are something that we will be concerned about, because with an overdose of opioids, then their recognition and of breathing, right, their own internal ventilations start slowing down and can eventually stop. So making sure that if we do have patients that have an opioid overdose, that we're making sure to check and maintain their airway and breathing. Tolerance of opioids develops quickly, so they are in constant need of needing more and more. Some users may require massive doses to experience the same high, so depending on how long they've been using. Often cause nausea and vomiting, so opioids can cause nausea and vomiting in patients. Usually seeing that in patients that, well, you can get nausea and vomiting from experience opioids for the first time, even with a legal prescription, right? It does have that effect on some people. Can also lead to hypotension, so low blood pressure in patients as well. Because of the depressant, they can appear sedated or unconscious, and then because their respiratory drive is not working as it should be, it is depressed, they could be cyanotic, so blue, right, bluing around the lips, the ears, the fingertips, and they could also have pinpoint pupils, right? We've talked about opioids where they have constricted pupils. Even if you are shining light, it's not gonna dilate and constrict like they should. So what do we need to do for these patients? We need to open their airway, make sure they're breathing, give them supplemental oxygen, and be aware and be careful if they do start vomiting. Narcotic antagonists are the only antidote for this. So we do have opioid antidotes, which is Narcan or naloxone, but that blocks the receptors for the opioids in the brain. And so if there is opioid overdose, narcotic overdose, we can pull our patients out of it and essentially pull them out of their high as well. So we do get patients that are really aggressive, that wake up and could be nauseous, vomiting, those types of things if we do give them Narcan. Narcan is not in the EMT1 scope yet. It should be next year. But we have had Narcan over the counter for some time now. So some patients might have a over the counter prescription, well, could have a prescription or get it over the counter. There are some kits around the borough for opioid ODs. So you can see them around town. Most times, if patients are prescribed some sort of opioid, they are given a Narcan prescription as well, to kind of counteract that, if you will. But Narcan is short acting. It's probably 10 to 15 minutes. So it does block those receptor sites until it's metabolized. And then your patient will go back into their OD when that Narcan wears off. So being aware of that as well. Moving into our sedative hypnotic drugs, barbiturates or benzodiazepines are easy to obtain, relatively cheap, and widely prescribed. Patients may appear drowsy, peaceful, and or intoxicated as well. So we can see things as like Xanax being one of these benzodiazepines that we're talking about, Valium, Ativan, these types of prescriptions. There's other ones that I'm not too familiar with, but there are barbiturates, and then other ones, even so inhalants we talked about, so hydrocarbon inhalants, or if people are drinking isopropyl alcohol, so rubbing alcohol, and then even ethyl alcohol, right? So regular alcohol counts as a sedative hypnotic as well. In general, these are taken by mouth, so occasionally the capsules are suspended or dissolved in water and then injected. So either taken by mouth or injected. So being aware of whichever route our patient's utilizing. Treatment is to provide airway clearance, ventilatory assistance, and prompt transport, because we're not going to be able to get this substance out of their body. It's going to need to work its way out of the body, so getting them into the ER and monitored for long-term support. There is an antidote for the benzodiazepines and some of the barbiturates, which is, flumazenil. But my understanding is that none of us in the borough carry flumazenil anymore. If we do, it'd be news to me, but that's a EMT 3 and paramedic skill as well. Whew. Okay, abused inhalants. So if they're inhaled instead of injected or ingested, things acetone, gasoline, toluene, hexane, whatever gases, can be found in glues. So people huffing glue, cleaning compounds, paint thinners, lacquers, gasoline and halogenated hydrocarbons as well. So all things that we could be potentially looking for when we're assessing our scene, right? Use special care if there are halogenated hydrocarbon solvents. So even those kind of like canned air whippets that people do, they can make the heart really sensitive. So to their own adrenaline, really. So it makes their heart hypersensitive if they do have an adrenaline dump that could into weird rhythms or cardiac arrest. So having our patients walk around or move, have them do that minimally. So we're going to be moving our patients instead of them moving to us. So even the action of it walking can throw them into weird heart rhythms. So being aware of that. Sympathomimetics, so CNS stimulants that mimic the effects of kind of like adrenaline, right? Our fight or flight. So these are going to be our stimulants. We have our amphetamines, crack cocaine, heroin, MDMA, PCP, these types of medications or street drugs that are going to be your uppers. So it produces an excited state, frequently causes hypertension, tachycardia, and dilation of the pupils. And designer drugs could be a potential as well. You want to be careful about kind of categorizing any overdose as one or the other, because people can do them together, and a lot of times they're referred to as speedballs. So you have an upper and downer together. So you might be getting conflicting signs and symptoms as well if you don't really know what they've ingested. For example, cocaine can be taken in a number of different ways. So it can be absorbed through the mucous membrane, so like through the gums. It can be snorted, it can be smoked, you name it. Cocaine can be through that route. Effects usually last less than an hour, but can be extremely potent, and things such as smoked crack. Cocaine is one of the most addicting substances known. Acute overdose is going to be a genuine emergency. It causes severe agitation, which will also agitate the heart, right? So tachycardia, and then you could also see hypertension in patients. You can get paranoid patients. We don't want to leave them unattended because of that paranoia, that risk running. And we do want to provide prompt transport and consider, depending on how your patient's acting, right, that paranoia, that delusions, maybe getting law enforcement involved. Marijuana has become legal in Alaska over the last couple of years, still is illegal in some states, but can be abused throughout the world. Well, it is. Produces euphoria, relaxation, and drowsiness, impairs short-term memory and capacity to do complex thinking, could progress to depression and confusion as well. Marijuana use rarely necessitates transport to the hospital. ODing on marijuana is not really a thing. Usually it's just high levels of THC, most of the time seen in edible consumption, where you get a lot of the hallucination or paranoia or anxiousness as to why we might have been called for patients that have ingested marijuana, ingested, smoked, whatever. Reassure patient and transport with minimum amount of excitement, right? Because if they are hallucinating or anxious or paranoid, not playing into that. And then being aware of marijuana being used as a vehicle to get other drugs in. So could be laced with something. There's that potential. What else? Hallucinogens. So alter a person's sensory perceptions. So things such as Jimson weed, like we talked about a little bit earlier, LSD, marijuana, mushrooms, PCP. There's also, I think it's, so nutmeg, but I think it's in the husk itself and not the nutmeg where you put it in baking, but could cause hallucinations. So visual hallucinations are usually what's being produced, intensifies vision and hearing, and then can separate the user from reality. So being aware that their perception of reality could be different. Patients experiencing a bad trip on these hallucinogens, right? You're going to get hypertension, you're going to get tachycardia, anxiousness, and paranoia. So high pressure, high heart rate, right? Excited levels. Be calm, be professional, provide emotional support. We're trying to refrain from restraints unless our patient's in danger of injuring themselves or others. And then watch them carefully throughout transport, being aware that we're reassessing them in a timely manner, and especially keeping an eye on their airway and breathing for sure. So anticholinergic agents we've touched on. With these, so Benadryl is going to be one of the biggest ones, especially the ones that I've seen, atropine and the Jimson weed. You get too hot, you dry out, and these are those signs and symptoms. So there's a little saying called hot as a hare, blind as a bat, dry as a bone, red as a beet, and mad as a hatter. That's kind of a saying about all these signs and symptoms that clue you into the anticholinergic agent that could have caused it. So because it blocks the parasympathetic nerves, that's why it does these things to the body. So you overheat, hot as a hare, blind as a bat, you can get more of tunnel vision, but also that perception is kind of lost. I had a patient that was just trying to grab, I was holding a pill bottle, asking him if that's what he had taken, and he was trying to grab it, but was just grabbing everywhere around it instead of the bottle itself. So that perception, depth perception could be off. Dry as a bone, so all their mucosa membranes kind of dry up. Red as a beet because they are kind of overheating, and mad as a hatter because they do become altered. Death from these agents can be rapid. So a patient can go from normal to seizing within like 30 minutes and then dead, right? So just because our patients look stable now, that continual need for reassessment because they can deteriorate pretty quickly. So transporting immediately, and then seizures and arrhythmias are best treated at the hospital. So making sure to get them transported and get them there. So we have cholinergic agents, so like nerve gases, insecticides, chemical warfare, and some wild mushrooms. So if people accidentally eat the wrong types of mushrooms. And what it does is it overstimulates things. So that's when you get like the sweaty, wet, and gross all over. So that lacrimation, the tearing, salivation, drooling, urination, defecation. So they're peeing and pooping and sweating and drooling, and it's all the things are overstimulated. So these are signs and symptoms of that cholinergic agent. So like insecticides would be a common one. And then mucus secretion, so all these things. And then it could affect your heart as well. So you could get a patient with an abnormal heart rate. The mnemonic for cholinergic agents is dumbbells. So defecation, which is pooping, urination, peeing. We have meiosis, which I believe is, I think that's like spitting up like a frothy, I'll look it up here. Bronchuria, so that's going to be that frothy spitting up. Emesis, which is going to be throwing up. And then lacrimation is that crying. And we also have salivation, so that's that drooling. And then meiosis is pupils. So it's going to be that constriction of the pupils. Sludge mnemonic is the one that I usually use for cholinergic because it's just wet and sticky and gross all over. Salivation, lacrimation, urination, defecation, GI issues, so gastrointestinal irritation, and then eye constriction. So those pupils constricting, and then emesis is that throwing up. So the most important consideration to avoid exposure, right? Making sure we wear our proper PPE, decontamination over transport, right? Because that might need to take priority. After decon, we can see a decrease in the secretions being produced, as well as we need to make sure that we support their airway. There are kits that are antidote kits that could be available. I'm not really sure where they would be in the borough if we do have any, but there's the Mark 1 or the Duodote kit, and really it's the atropine, which atropine will be on an ambulance, so we could be giving part of the antidote, but it's this atropine and 2-PAM chloride combination that'll counteract that cholinergic agent. But if we give a heads up to the hospital, having them be ready with if they can get their hands on an antidote kit. I'm not sure if they have one or not. And then we have miscellaneous drugs. So accidental or intentional overdose of cardiac medications. And a lot of this is due to like little kids getting into medicine cabinets of like grandma or grandpa. And so the potential of overdosing on medications that aren't usually overdosed on. So cardiac medications could be something we come into contact with. Fatally ingested poison, so benzocaine, which is like a painkiller of sorts, and it's if large amounts are ingested, could be fatal. There's a bunch of things on this list here. Visine is on here. Oh man, sorry. Visine is on there. So usually there was, I don't know, remember what movie it was, but putting Visine drops in someone's drink and then they have massive diarrhea. But if you ingest too much of it, right, it could be fatal. So signs and symptoms will vary depending on whatever medication it is. Might be given that order to administer activated charcoal. So it is in our standing orders to give it, but if we have any questions about it or what they've ingested, poison control or medical control. And then aspirin poisoning, remains a potentially lethal condition as well. So any sort of over-the-counter painkiller medications, like aspirin or ibuprofen or things of that nature, really do take their toll on your internal organs as well. Not only short term, but long term as well. So people try to commit suicide with pain pills, and a lot of them. It usually breaks down their stomach lining, um, leads to kidney failure, leads to liver issues. It's just not good. Okay. So overdosing with acetaminophen is common as well because it's easily accessible. It comes in large bottles with hundreds of pills at a time. So that could be one of the potentials. Being careful with children who've ingested the poison, and then some alcohols are even more toxic than regular drinking alcohol, right? So methyl alcohol, like rubbing alcohol, is not meant to be ingested and can really be super caustic to our system. So we can also go over things such as food poisoning, right? Which usually isn't as big of an emergency, right? It's not super fatal, but we can have different types of food poisoning. So from the organism itself that causes the disease, or that organism produces toxins that cause the disease. So some common ones would be like botulism, salmonella will be another big one. So salmonellosis, uh, different poisoning, you get within 72 hours. So upset stomach, diarrhea, cramping, nausea, vomiting. Usually proper cooking will kill the bacteria and proper cleanliness. But depending on how you got the food poisoning, you can get these sorts of signs and symptoms. The more common cause of food poisoning is the ingestion of powerful toxins produced by the bacteria, so Staphylococcus, which will grow and become toxic while it grows on the food. And then any foods prepared like with mayonnaise or something that is left unrefrigerated that breaks down can grow the Staphylococcus. The most severe form of toxin ingestion will be botulism. And so in Alaska, there is still botulism cases, and a lot of the times it's due to canning, improper canning or improper storage of canned goods. What happens is it's a neurologic effect in patients. So you get blurred vision, weaknesses, difficulty speaking and breathing, just from ingesting this botulinum toxin. And botulism that ingested being different than like Botox, right? That's injected. Different strains, different uses. So it's not really our job, and we're going to have a hard time determining on our own the specific cause of the GI problems. What we need to know is that there are GI problems, what specific things are happening, what may have led to the cause of this, and history taking, and then prompt transport. So, and then also being aware of multiple people with the same signs and symptoms. So could clue you into the fact that, well, when we talk about airborne stuff, right? Carbon monoxide, you have multiple patients in one room now exhibiting the same signs and symptoms. You have patients that are exhibiting the same signs and symptoms because they've ingested the same thing, not that it's an airborne thing. So kind of history taking, environmental considerations, and so on and so forth to determine the differences. So we could also have these sort of plants causing issues. So whether these plants are ingested or touched or whatever, usually ingested, and they could be plants that that patients just have in their house, or they're trying like supplements, right? Like health food store supplements, or trying to make their own. But there are several thousand cases about plant poisoning annually. So being careful of those types of issues. So we can look at this extensive list here. But like water hemlock, poison hemlock, Jimson weed has come up a couple times, foxglove, tobacco, mistletoe, which is actually poisonous while ingested as well. So you can see that being an issue, especially during this time of year, Christmas time-ish, going into Christmas time. So those are potential if in case kids ingest them on accident. So it really is impossible to memorize every plant or poison, and let alone the effects. So that's why usually we are treating the symptoms of whatever's being caused by the substance. And then we can also call poison control because they have information on it, on specifics, if we know what it is, and can gear us towards the proper treatment and management of these patients. If you do have the plant, taking it to the ER for identification as well as testing, and then providing prompt transport. So seeing different examples of plants. Irritation of the skin or mucous membranes is a problem common with a specific type of house plant. But what happens is that airway can be affected. So we want to maintain that airway and transport promptly. So, I mean, you can kind of see that there are multiple different things that can cause issues, but what we need to be aware of are collecting signs and symptoms and recognition that it's a poison, and then transporting promptly. Not that our job is to pinpoint what plant poison or what it is, because a lot of the times we're not going to be able to tell. So emergency treatment may include administration of the antidote if there is one that exists. Seeing if we can determine how the plant is introduced into our patient's system, right? Is it topically? Did they ingest it? Did they inhale it? Those are going to be pretty much our job. And then it's going to be difficult to remove any poisons, but if we can, right, we brush it off before we rinse it off. If it's injected, we just need to be aware of that and make sure that we treat the signs and symptoms and then transport promptly. Making sure to utilize poison control is going to be a big thing as well. I want to show you guys, let's see, anticholinergic. So there's those sayings, right? Bad as a hatter, blind as a bat, and there's these visuals that I like showing. What are anticholinergic? Mnemonic? There he is. Toxidrome. That's the word I wanted. So the anticholinergic toxidrome. So it's a picture of the Mad Hatter. That's what it's supposed to be. But it's another thing to just kind of remember it. So hot as a desert, blind as a bat, mad as a hatter, dry as a bone, dilated pupils, red as a beet, And then you can see tachycardia, absent bowel sounds, grabbing at those invisible objects, or that depth perception, right? So the Mad Hatter in a desert, kind of toxidrome to remember these anticholinergic poisonings. And then cholinergic is opposite, right? So you're going to get that wet, gross all over. This guy. So this one's also our sludge mnemonic, right? Salivation, lacrimation, urination, defecation, GI issues, and MSS. But you can see sweating, crying, runny nose, vomiting, pinpoint pupils, frothing at the mouth. He's reading bradycardia times, so low heart rate, diarrhea, urination, and then it's got this box of insecticide here that shows that type of poisoning can cause these types of signs and symptoms. So these toxidromes are pretty interesting. And I like the graphics. It's pretty memorable for me, at least. All right, any questions on any of that so far? Doesn't look like there's any chat either. Okay, we're gonna take our break a little bit early today. It's 7:47. So come back at 8 and we'll go over behavioral and psych emergencies. All right. So we're going to jump into psychiatric emergencies and kind of along the same lines of our overdose patients. There's not a whole lot that we're going to be able to do other than recognition, as well as patient advocacy, really, and then treating any signs and symptoms that are associated. So there is a wide scale, a spectrum, if you will, of psychiatric type emergencies, and they usually run the gambit. So being careful on these types of calls and recognize that sometimes these behaviors can be a risk to ourselves, to our patient, to others. So being mindful of that. And then assessment and management of basic principles of the mental health system, as well as the suicide risk that our patients present as. We don't have the greatest mental health support or even behavioral hospitals or anything like that up in Alaska. We do have a behavioral floor, the 5th floor of the FMH. We do have some psych rooms in the ER, but we don't really have the best setup for behavioral health type stuff. So being aware of that as well. We'll go over things such as acute psychosis, agitated delirium, cognitive disorders, thought disorders, mood disorders, and neurotic disorders. Substance-related disorders and addictive behavior, which we kind of touched on with our toxicology. Somatoform, factitious personality patterns, and organic psychosis. So mind and body are inseparable. The illnesses affect a person's behavior, and then changes in mental state will affect their physical health as well. Most experts define behavior as the way people act or perform. So you have overt behavior or covert behavior. And overt behavior is generally understood by those around the person. And then you have covert behavior, which has hidden meanings or hidden intentions. So we have the separate definitions of behavioral emergency versus psychiatric emergency. So behavioral emergencies are disorders of mood or thought or behaviors, while psychiatric emergencies are behaviors that threaten a person's health or safety and the health and safety of another person. Behavioral or psych emergency is defined by the person who dials 911, right? So whoever dials 911 has decided that that's an emergency that needs to be intervened upon, and whatever their description to dispatch is and how it gets relayed to us. So prevalence, an average number of mentally unhealthy days for Americans has increased. So from 93 to today, 2.9 to 3.5 days per month. And a lot of it too is recognition that they are mentally unhealthy type days. 4.1 million US adults with any mental illness in the past year, and that number does increase. And I think a lot of it has to do with the recognition of mental illness as well. Medical legal considerations: when behavior, speech, and thoughts are erratic, it can be difficult to communicate with these patients. It is going to take longer, and time is going to need to be spent talking to them, convincing them, and then kind of a lot of the times orienting them to reality sometimes. Obtain consent when possible. If law enforcement needs to get involved, law enforcement needs to get involved. We want to be clear and concise in our explanations of what we're doing and why we're doing it. No surprises. Causes of abnormal behavior. So the broad categories: biologic or organic, resulting from the environment, resulting from acute injury or illness, and potentially substance related. So biologic or organic, we're talking about organic brain syndromes or conditions that alter the functioning of the brain. We have environmental, so we have psychosocial or social cultural influences. When people are consistently exposed to stressful events, patients can develop abnormal reactions. And then sociological factors affect biology, behavior, and responses to stress stressful emergencies. Injury and illness. So illness results in stressing on coping mechanisms, and then acute trauma creates stress. So you can have a post-traumatic stress disorder. You can also have substance-related abnormal behavior, right? So alcohol, which we had touched on already from the last lecture, on how it can get people agitated. It decreases their cognition and their memory. Cigarettes, illicit drugs, other substances can be related. Psychiatric signs and symptoms. So when mental health is challenged, mechanisms or behaviors work to return to homeostasis. So present as psychiatric signs and symptoms. So the body's always trying to get back to a homeostasis, whether it recognizes homeostasis as we do, or its imbalance as homeostasis. So a chart here kind of outlines the signs and symptoms for different disorders. And realistically, we're not going to be able to distinguish one disorder from the next. That's not really in our scope, in our training, to differentiate any of these type of mental illnesses. But signs and symptoms are what we can do and have control over. So disorders of consciousness, distractibility and inattention, confusion, delirium, stupor, and or coma could be disorders of consciousness. Disorders of motor activity, so restlessness, stereotype movements, so repetition type movements, compulsions, so repetitive actions, like OCD or those types of obsessive compulsive stuff, or even slow movements. Disorders of speech, so slow speech, acceleration of speech, words the patient invents, so they could be making up words, echoes words, or even doesn't speak at all. And you can see how this kind of goes and ranges throughout the spectrum, right? So it kind of, you'll see, and it'll range differently for every patient. Disorders of thinking, so flight of ideas, so accelerated thinking, slowness of thought, perseveration, which is an interesting one, and I've seen it in trauma, so car accident patient, and it's repetition of the same thing over and over again. And so it could be because of mental illness, could be of trauma. There's a patient that was in a car accident and hit their head on the windshield and would just ask over and over again who we were and what we were doing. And I think asked probably like 30 times by the time we got her extricated out from the vehicle. So it was like a short-term, it seemed like a short-term memory loss, like 10-second Tom type stuff, but it happens. So could also have circumstantial thinking, disordered thought content, so delusions, obsessions, or phobias, mood and affect disorders, anxiety, euphoria, depression, disorders of memory, amnesia, orientation problems, perception problems, or even difficulty learning. So there's a huge range that we can see. Assessment of the patient with behavioral emergencies differs from other methods. So we are that diagnostic instrument, and assessment is going to be a part of that treatment. So assessment, recognition, all those things. Situations with a strong behavioral component may have a sudden and unexpected turn of events. So making sure that you keep your situational awareness up and make sure that that flip hasn't switched and now it's dangerous for you to be there. This one's a little hard to see because of how small it is on the slide, but these are safety guidelines. So assess your scene, be prepared to spend extra time on scene, have a plan of action, identify yourself, be direct, stay with the patient, encourage purposeful movement, express interest in their story, keep a safe distance, avoid fighting with your patient, be honest and reassuring, and non-judgmental. So being aware that it's going to take more time, but also to kind of be cognizant that these patients without warning can kind of flip a switch, and we just don't know. So always kind of make sure you're not cornered, you're not alone with your patient, knowing an exit route, which sounds kind of scary, but being aware of all that. Their environment can give you clues into kind of their condition, right, on how they treat themselves and their environment around themselves. So also social history, living conditions, that availability of support, their activity level, medications, overall appearance, and attitude or well-being can kind of give you clues into kind of how they operate on day-to-day. And is this within their realm of normal, or is it abnormal for them? Most likely going to be abnormal, hence the reason why we're there. So we always want to clearly identify ourselves, so we don't know what type of emergency realistically we're walking into, right, with behavioral or psychiatric. You just don't really know. So identify yourself, why you're there, what you're doing. Form a general impression, so assess their appearance, their posture, and even their pupils. But posture is going to be a big one too, to see if they're kind of on the defensive or if they're kind of calm and collected. Limit the number of people around the patient. Even with a patient not going through a behavioral or psychiatric crisis, you can get kind of overwhelmed when there's a bunch of strangers kind of hovering and standing around you, the patient, that's not having the greatest day. So just being mindful of that as well. And then staying alert to any potential danger. We're assessing their airway and breathing just as we would anybody else, and we're going to intervene if necessary, depending on whatever we find. And then circulation. So we're going to get that pulse rate and quality, and then evaluate for shock and any external bleeding and how they're perfusing. Okay, we're not doing blood pressures until later on in our assessment. And then transport decision. So behavioral or psych patients are going to need to be referred to the behavioral section of the hospital. So they're usually going to get taken to the ER, go through and get assessed, and then either put in one of the psych rooms or sent up to the psych floor if there's space. If they do withhold consent, they may be taken against her will, right? So getting the law enforcement involved, so that way if they do need to get titled because for their own safety or safety of others, that's done. Same applies to forcible restraint, right? We're not restraining anybody unless they're a harm to themselves or others, but we're also getting law enforcement on scene before we do that or as soon as possible after. So we could do a mental status examination, which Coast Map is what's utilized. I don't use Coast Map much. I don't haven't really extensively gone over it, but it is a tool. And so consciousness, so the level and concentration. Orientation, do they know the year, the month, and where they're at? Activity, sort of behavior and movement, and then speech, rate, volume, flow, articulation, and notation. Thought, so are they making rational sense? Memory, recent, remote, or immediate. affect and mood. Do the inner feelings seem appropriate? And then perception. Do you hear things that others can't? Type questions. So then we're getting vital signs, right? Skin, color, temperature, condition, head and pupils, making sure that they're not altered because of trauma. And then any unusual odors, right? Could they be intoxicated? Could they be a diabetic? These are all things that we're thinking of as well. In examining the extremities, right, the arms and legs, looking for needle marks, any tremors, unilateral weakness or loss of sensation, right? So when we do our extremity pulses and motor function, we want to do it bilaterally, right? Because we want to test and see and feel, do the pulses feel the same on both sides? Can they move on both sides? And if we're pushing down or pulling up on the feet or squeezing on the hands, is that stronger on one side or weak on the other? We want to determine that. And then sensation, we're doing that sensation test. Can you feel this finger that I'm touching? Blah, blah, blah. Okay. So noting any deficits. And then reassessment, we're performing every 5 minutes or every 15 minutes, depending on how stable they are. And then we're doing this during transport. And our radio report to the incoming unit or into the hospital would be medical and mental health history, medications prescribed, assessment findings, and then any other information upon examination. Discuss with the hospital. So when you're en route, getting in contact with the hospital and giving them that verbal report, but also if they're restrained or if they need chemical restraints, right? If they're aggressive or violent, do tell the hospital that ahead of time. They'll be very appreciative that you don't just show up with a combative patient, right? Give them a heads up. If the erratic behavior could be caused by medical disorder, treat that before presuming the behavior is due to an emotional or psychiatric cause. So potential, is it being caused by an overdose? Are they intoxicated? Are they diabetic? Something like that. Communication techniques, so open-ended type questions instead of pointed ones. Let the patient talk, listen, and show that you're listening to your patient and their responses. Don't be afraid of silences. Acknowledge and label their feelings. Don't argue with your patients. Facilitate that communication and that back and forth dialogue. And then direct the patient's attention, so being aware of doing a redirect if there is indeed confrontation. So we kind of avoid the yes and no's type questioning versus the hows and whats. So more open-ended, get them to talk, to explain, to elaborate. So crisis intervention skills are part of what we'll do as well. So be calm and direct, and exclude disruptive people. So sometimes there are people who try to chime in and answer for your patient. Usually we try to separate that person and have one of our partners or another EMS or fire, whoever battalion's on scene, to separate them and question them separately, so that way we can deal with our patient and not have disruptive people or people trying to comment and answer for our patient. And being aware of kind of your posturing as well. So when patients are sitting down and you're standing and hovering over them, it can be seen as, well, sometimes it could be looked at as aggressive, or it could be not professional. It's hard to say, but it comes across different. So making sure that you're more at eye level, take a seat, or anything like that, just being aware of your patient's behavior, and if it changes, right? Not putting yourself in danger by being in those types of positions. Maintaining a non-judgmental attitude, provide honest reassurance, and develop a plan of action. And then once the plan's set, allowing the patient to kind of be an advocate within their own care. Encourage some motor activity. So with patients, they like to feel like they're in control of their care. So that's sometimes I'll give our patients that non-rebreather to hold and have instead of strapping it to their face. Putting that pulse oximeter on their hand and having them monitor it for me. Simple tasks that are not a big deal, but gives them some sort of level of control and participation. Any medications that they have or that you found, bring them with you. And never assume that it's impossible to talk with your patient until you've tried. So always just try to talk to them. Leave those open-ended questions. Maybe some of the communication will be nonverbal, more body language type stuff. If you do have to use physical restraints, know where they are in your ambulance. Sometimes they're pre-positioned on the gurney. Sometimes they're in a separate area. Most of us are going to be utilizing commercially made devices because they are for use in our ambulance. But knowing that there could be some improvisation there if necessary. Make sure you have sufficient personnel and minimum of 4 trained able-bodied people, and 5 preferably, because 1 at each extremity and then somebody at the head, making sure airway breathing is still happening. Discuss the plan of action before you begin. Include law enforcement. Use the minimum force necessary, and just plan your approach. Don't immediately move towards the patient. But usually if they're combative enough, it's law enforcement that's going to be doing the restraining and helping attach to your gurney as necessary. If the show of force doesn't calm the patient, move quickly, grasp at elbows, knees, and heads, apply restraints to all 4 extremities, and the best position is supine, so laying them on their back. We as EMS never tie ankles and wrists together. We don't hobble tie or place them face down. General rules, right? Once restraints are in place, we don't remove the restraints. We don't negotiate or make deals, and we can place a mask over them if they're spitting. Law enforcement can sometimes have those like mesh, I hate calling them bags, but they are, that go over the patient's head if they're spitting. But we can put surgical masks or something on them as well. We also don't want to place patients face down, which is important because we want to be able to assess airway and breathing and intervene if necessary. So this is an example of a padded restraint that'd be utilized. It's a commercially designed restraint. And so 1 on each extremity. We want to continuously monitor our patients, and we also want to make sure we're getting our CSMs, right? So circulation, motor, and sensation on their hands and feet, especially because they are restrained. Be careful to if your combative patient suddenly becomes calm. I would assess airway, breathing, and circulation. See if their condition's deteriorating, or be prepared for something to happen. Document everything in your patient's chart. So what was done, why restraints happened, if law enforcement was on scene. And you may defend yourself against an attack, right? To prove that restraints are necessary. With ALS on scene, the potential to utilize chemical restraints. So instead of physical restraints, it's medication. So it's a mixture of different medications in a syringe that are injected, right, and sedate patients. Different sort of behaviors are caused by some sort of different disorders. So you have cognitive disorders like agitated delirium, thought disorders like schizophrenia, mood disorders, bipolar, manic, or depressive, neurotic, anxiety disorders, phobias, panic disorders, substance-related disorders, so substance abuse, intoxication, dependence, eating disorders, hypochondriacs, so some somatoform disorders, conversion disorders, factitious disorders. There's that ranges that whole spectrum, that whole list. So for example, acute psychosis, a person kind of out of touch with reality, could occur for various reasons. Episodes can be brief or they could last a lifetime, right? So that psychosis can be something that we're going to be aware of and be careful of. It's a profound thought disorder, and a thorough exam is rarely possible, but definitely transporting the patient in an atraumatic fashion. So transporting them as gentle and as possible. So with patients in acute psychosis, it may take a lot longer on-scene time than initially thought. So reasoning doesn't always work. Explanations about what's being done will be necessary. Keep directions simple and consistent, and keep orienting your patient to reality. So maintaining emotional distances, explaining each step, involving people the patient trusts, so caretakers, family, friends. Restraints and or medical chemical restraints might be necessary. So agitated delirium is a state of global cognitive impairment. Dementia is more of a chronic process, but patients become agitated and violent, and patients can send themselves into agitated delirium with high levels of medication overdoses. So overdose patients can put themselves into an agitated delirium stage as well. Trying to orient patients to reality, performing a thorough assessment, and then identify the stressor of what's got them agitated, or it might just be a metabolic issue. I do have a video. Let's see if I can pull it up. Of agitated delirium. I wonder which one it is.
A lot of the stuff on Signal Wire.
Oh, that's a seminar. Let's see. There's one where a guy punches a fence. Aha. I think it's this one.
He is right there. Hey, get on the ground! Hey, get on the ground!
Just sit down, man. Right, yeah. Told traffic for Clark. Right, yeah. Square down.
Come on, man. Sit down.
Turn over. Turn him. What was that? Come over. Turn him. Okay. Cuff him. Get the cuffs on him. Grab hold this arm.
Use two cuffs.
Grab my cuffs.
I got him. We got him.
So this video I like to use as an example because of, I mean, they did successfully restrain him. Hold on, let me stop that. But what had happened was because of that excited stage, he had a really high heart rate, really high respiratory rate, right, and super agitated and hyperthermic, right, overheated. And when these people come to a complete stop, like put in handcuffs and on the ground, I think this guy as well, I did a EMS conference where they showed that video, and they said that he was transported face down because of how they handcuffed him and hogtied him, that it depressed his respiratory drive, and then he essentially died because nobody really noticed. So that one I like utilizing because it shows that just total disassociation, right, with reality. And you can see, I mean, he's naked, right? That hyperthermia, that overheating, they usually strip down. So those are potentials that we can see and be aware of. So agitated, restrained patients suddenly becoming calm, we want to be really conscious about. Suicidal ideation, so any willful act designed to end one's life. So risk factors, Alaska has one of the highest incidence for suicide attempts and successful suicides in the nation. So being aware of that, and especially seasonal depressive disorders kind of make those numbers skyrocket during the winter months. Depression or sudden improvement in depression, males under the age of 55, single, widowed, or divorced, alcohol or drug abuse, recent loss of spouse or significant relationship, chronic debilitating illness, schizophrenia, suicidal thoughts or concrete plans, if they're Caucasian, social isolation, previous suicide attempts, financial setback or job loss, and any family history of suicide. So these are all risk factors that can come into play. Every depressed patient should be evaluated for suicide risk, and most patients are relieved when the topic is brought up. A lot of people dance around the subject, and nobody really asks that direct question of, are you thinking about killing yourself? Do you have a plan, sort of questions. So instead of kind of hard hinting at it or dancing on the subject, that straight up question for a straight up answer. So broach the subject in a stepwise fashion. High risk patients include patients who have made previous attempts. So if they've attempted before, they're at a higher risk. If they have detailed or concrete plans, and if they have a history among close relatives that have committed suicide as well. So higher risk. We don't leave these patients alone. We collect implements of self-destruction, right? So any sort of anything that can be utilized to harm themselves, acknowledgement of their feelings, and then encouraging transport, right, to the hospital, to the psych rooms, and evaluation. Patterns of violence and abuse and neglect. Assess the following. So assess your patient, their environment, and other people involved. Document your findings and report your concerns according to local protocols. So remember, we are mandatory reporters when it comes to any suspected abuse or neglect cases. Violence. So most angry patients can be calmed by a trained person who conveys confidence. Sometimes with any violence, law enforcement, we're getting them involved if they're not already. Be prepared for any hostile or violent behavior, and preventative action is going to be the best. But law enforcement being there on scene with you is going to be pretty vital. So being careful about posturing of patients or even bystanders or family members. But so how they're positioned, right? Are they sitting? Do they look tense? Do they have clenched fists? Are they loud or threatening? Do they look agitated? Are they unable to sit still and are kind of fidgeting, right? These are all things that we can be clued in on of a nonverbal type of communication. Assess the whole situation, observe your surroundings, maintain a safe distance, and then our interventions are verbal at first, but getting law enforcement involved and restraining might be a potential. Mood disorders, so unipolar mood disorders, mood remains at one pole of the continuum versus bipolar, mood alternates, mania, depression, back and forth. Manic behavior, so abnormally exaggerated happiness with hyperactivity and insomnia, could be pressured and rapid speech, tangible thinking, and grandiose or unrealistic ideas. So these are that manic, when patients are in their manic stage or mania, can be kind of like really up, right? Really high energy, crazy ideas, usually unrealistic ideas, and just super high energy. Usually counteracted with depressive episodes, so that low after that high. Be calm and firm with the patient, minimize any external stimulation, and if they refuse transport, call medical control, tell them what you're seeing and perceiving, and then if law enforcement intervention is necessary, knowing that you have that as an option. And then depression, so leading cause of disability in people 15 to 44, occurs in episodes with sudden onset and limited durations, but onset can also be insidious and chronic. So they can have different episodes, but they can have episodes really, really often, right? And then be more of chronic depression. So diagnostic features, gas pipes, guilt, appetite, sleep disturbance, paying attention, interest, psychomotor abnormalities, energy, and suicidal thoughts can all be diagnostic type features of depression. Again, not our job to diagnose, but if we do recognize certain signs and symptoms and any of these patterns of behaviors, that we can kind of gear our treatment and recognition and telling the hospital kind of what we've observed that might line up to these types of disorders. Schizophrenia, so onset occurs during early adulthood usually. Experience may include delusions, hallucinations, a flat affect, or erratic speech. So different types of ways on how it would present itself. Neurotic disorders, collection of psychiatric disorders without psychotic symptoms, includes anxiety type disorders, mental disorders, which are dominant moods, so like fear-based disorders, or apprehension, like not leaving the house, things of that nature. Generalized anxiety disorder, so worries for no particular reason, may prevent decision-making abilities, and usually on medications and counseling. So looking at their medications and even looking up what the medications are used for can kind of clue you into what might be going on if you have an altered patient. So identify yourself, be calm, confident, professional, listen attentively, talk about their feelings, what they're going through, and just listen and be there, do the open-ended questions, right? These patients might take a lot longer on scene time. Certain phobias, so unreasonable fear, apprehension, or dread of specific situation or thing. Simple phobias focus all anxieties on one class of object or situation. So some of these phobias might be debilitating. When managing a patient, we're always explaining step by step what we're doing, but being very cognizant of doing so with patients that are going through some behavioral or psychiatric kind of disorders. Panic disorders, so sudden feelings of fear and dread. If allowed to continue, panic attacks can cause lifestyle restrictions, so like agoraphobia, fear of going out into public places. Signs and symptoms can usually peak in about 10 minutes, but because of these panic attacks being so strong, it really does affect our patient physically. So you can see the rise in heart rate, high blood pressure, shortness of breath, tachycardia, we already said, but also palpitations. And so we can kind of see how the panic manifests physically in our patients as well. So sweating, nausea, flushes or chills, dizziness, fainting, right? Paresthesia, so mild paralysis. And some of this has to do with how their respirations are, on how fast or how shallow during this panic attack, that it can cause these physical kind of symptoms. So with these types of patients, if there's any panicking bystanders, right, separating them, not needing to play into more of this panic disorder. Be calm, be tolerant, reassuring, give the symptoms a name, right? So if we're, instead of just labeling them as freaking out or panicking, right? They do have a high heart rate, tachycardia. They might be hyperventilating, right? So giving these symptoms a name and labeling them instead of just having our patient freaking out. And then describing what's happening, trying to coach them to bring their breathing rate slower and help your patient regain some sort of control, because in panic disorders, feeling out of control is exactly what's happening. So trying to regain some control, trying to get them to be advocates for themselves and then participate in their own care. So again, that oxygen mask, and that non-rebreather, it's a great way to get your patient involved and kind of distracted, right? But holding that non-rebreather to their face or even blow by, but being a part of their care to be able to give them that. Substance-related disorders. So in Alaska, and especially in the interior, we have a high instance for substance-related disorders that we run on for patients. We do have a really high, I don't know if it's per capita, but instance of alcohol and drug abuse as just throughout the state as well. So a lot of our calls are kind of related, especially the city of Fairbanks has a lot of those types of calls. Substance use, substance intoxication, abuse, and dependence. Determining the most effective treatment requires an integrative approach. So different disorders. So there's different eating disorders, but because of the eating disorder, there's an imbalance, usually of electrolytes. 2/3 report anxiety, depression, and substance abuse disorders on top of eating disorders. So bulimia nervosa, consumption of large amounts of foods compensated by purging. So it's binging and then throwing up and purging. And then anorexia nervosa is weight loss that jeopardizes their health and lives. Typical patient has decreased body weight, depending on their age and weight, intense fear of obesity, and then experience amenorrhea. So they have different issues because they're not eating anything of substance or anything at all, really. And they can kind of, they can have these different signs and symptoms showing up because of that imbalance, right? And so this amenorrhea, especially too, is in women, which anorexia nervosa is a high instance in women, but they also don't get their period. So in after puberty, right? Because of that imbalance, they could also have no period. So hormone imbalance as well. Somatoform disorders, so preoccupation with physical health and appearance, so hypochondriacs, right? That they have the fear of them having some serious disease or disorder that they might usually don't have, right? And then some sort of conversion disorder, so serious problem resulting from faking a physical disorder. So usually they're faking a disorder that they think's going on with them that causes something else to happen, like a physical problem. Factitious disorders. So patient produces or feigns physical or psychological signs or symptoms, but they're under voluntary control. Or it could be by proxy, so a parent that makes a child sick, usually for attention. Impulse control. I mean, with some of these disorders, not usually being high instance of medical intervention necessary, like kleptomania, stealing, pyromania, setting stuff on fire, right? But these are all examples. Personality disorders, medications for psychiatric disorders. So making sure we get history, right? What medications are on, and any pertinent past medical history that could kind of indicate what's going on. So antidepressants, when you're running on patients, there's a high instance of you coming across somebody on antidepressants. It combats the symptoms of depressive illness and alters neurotransmitters of the ANS, autonomic nervous system. So amitriptyline is a very common antidepressant, and there's a bunch of these that you can see. Trazodone's another one. Wellbutrin's another one. So just knowing kind of these common names, and that'll clue you in, right? If you find a prescribed medication, it clues you into some sort of disorder that that medication is for. Okay. Benzodiazepines we touched on with our overdose, but usually prescribed for more emotional distress type orders. Antipsychotics, amphetamines, like ADHD, you can have patients that have amphetamines that are prescribed. What else? So non-compliance with medications, I think, would be a high instance of why we are there. So patients that have not been taking their medications, maybe they've been feeling a lot better since being on the medication, so then they stop and then kind of revert back. So that might be more of an instance on why we're there and why they're now in a behavioral or psychiatric emergency, right? So making sure we ask those medication questions, but also, are you taking them? Are you prescribed them? Are you supposed to be taking them that you're not? Whatever. Okay. All right. It is 8:50. So we'll see you at 9. We'll go over bleeding and shock, and then we'll be done for the night. Okay, to kind of round out our behavioral and psych emergencies, I'm going to utilize the Khan Academy again. We'll go over the overview of psychoactive drugs as well as introduction to the psychology of depression and major depressive disorder. And then we'll jump into our bleeding and shock lecture, which will be the last of today's lecture.
Psychoactive drugs are drugs that can alter our consciousness. They can alter our perceptions, influence our moods, calm us down, make us feel more alert, etc. And we classify psychoactive drugs based on the actions and effects that they have on our bodies. And when we do this, we wind up with 4 main groups: depressants, stimulants, hallucinogens, and opiates. Drugs that are classified as depressants depress our central nervous system functions. So they decrease the level of arousal or decrease the level of stimulation in certain areas of our brain. They decrease our heart rate, lower blood pressure, slow our breathing. They can cause dizziness and lack of coordination. And importantly, they lower our processing speed. And this is important because it can affect how we interpret and react to the things that are going on around us, because it'll cause us to think more slowly and to act more slowly. And there are a number of different types of drugs that fall under this heading. One type is referred to as barbiturates, and these are also sometimes referred to as tranquilizers. And these are drugs that are sometimes prescribed to individuals to help them sleep or to help them calm down. And they are also sometimes used in general anesthesia or as an anticonvulsant. But the truth of the matter is that these drugs aren't actually prescribed very often because of the side effects that they can have and because they have a high addiction potential. So they've mostly been replaced by another type of depressant, which are called benzodiazepines. And these are prescribed for the same thing. So they're prescribed to treat insomnia and anxiety. And they're also used to treat seizures since they can depress out of control activity. The last depressant that I want to point out is alcohol. And it might surprise you that alcohol is characterized as a depressant since it's associated with going out to bars and flirting and dancing with friends. But rather than producing a stimulating effect, what is actually going on is that alcohol is lowering their inhibitions. So it's decreasing their cognitive control. And so people who might not generally dance in front of others, alcohol is stopping the thing that would generally stop them. And of course, all of the other symptoms of depressives are also present for alcohol, things like lack of coordination and slurring of speech, etc. The next class of drugs that I want to talk about are stimulants. And if depressants depress our central nervous system functioning, stimulants excite it. So they stimulate our central nervous system. They increase our heart rate and blood pressure, and they increase our alertness. And so when people take them, they feel more awake. They feel more alert and energetic. But they can also make people really nervous and jittery and make them unable to sit still. And you are probably very familiar with one legal stimulant in particular, and that is caffeine. And this is the part of Coke and Pepsi and also coffee that helps to keep us awake. And you may have heard of other stimulants as well, things like amphetamines, like Adderall, also methamphetamines and MDMA or ecstasy or Molly. Cocaine is also a stimulant, as is nicotine. And nicotine is in fact a stimulant and not a depressant. Even though it can cause relaxation, it can also make people more alert. One thing that I want to point out before I move on to the next class of drugs is that while depressants and stimulants are functionally opposites, they don't necessarily work on the same things on a neurochemical level. And this is one of the reasons why you can't actually take one to counter the effects of the other. Drinking coffee after you have had a lot of alcohol won't actually sober you up. It will just make you a more alert drunk person. The next class of drugs are hallucinogens, and these are sometimes referred to as psychedelics. And these drugs cause individuals to experience distorted perceptions. And this can include hallucinations, so seeing or hearing things that are different from how things actually are. But they can also cause heightened sensations. So sensations that feel real and might be based in reality, but are actually different from what is really going on around them. And to be clear, these drugs aren't stimulants or depressants, even though they can give people a lot of energy or sometimes calm them down a lot. Instead, these drugs are really classified by the perceptual changes that they bring about. And that can include a ton of different things in addition to hallucinations. It can also include emotional responses, feelings of connectedness, but also intense mood swings, moods that change very rapidly. And this brings up a really interesting point about hallucinogens, which is that the exact experiences felt by the individual can be different depending on the individual personalities or where they are or who they are with. And this class of drugs includes things like LSD, which is sometimes referred to as acid, psilocybin, which is an active ingredient in mushrooms, and also things like peyote and PCP. The last class of drugs that I want to talk about are opiates, which are sometimes called opioids. And these terms are actually used interchangeably, although there is one small distinction, and that's that the term opiates is generally used to describe natural varieties, while opioids is used to discuss synthetic versions. Like depressants, opiates can depress central nervous system functions, so they can decrease heart rate and blood pressure, they can feel relaxation and induce sleep. And because of this, they're sometimes lumped under the heading of depressants. But there are actually important distinctions between them. The main one is that they actually work on different mechanisms on a neurochemical level. Opiates also have an added feature that also distinguishes them from depressants, and that's that they are an analgesic, so they reduce the perception of pain. Some opiates that you might have heard of include morphine and codeine and heroin, but it also includes other substances like oxycodone and Vicodin. So here we are, we have 4 classes of drugs: depressants, stimulants, hallucinogens, and opiates. And it might seem that things fit neatly into one category or another, but the fact of the matter is that this is not a perfect system. And that's because we created the system of categorization. Nature did not. And because of this, not all drugs fit neatly into one category or another. So before, when we talked about MDMA or ecstasy, we placed it in the stimulant category. But it also could just as easily belong in the hallucinogen category, since it does cause distorted perceptions and heightened sensations. And what about cannabis? Where does marijuana go? It can cause perceptual distortions, so it could go under hallucinogens, but it can also decrease central nervous system function and cause relaxation, much like a depressant. And of course, this is just one way to classify psychoactive drugs. We could also have sorted them by legal status or how likely they are to be abused. Major depressive disorder, which is sometimes just referred to as depression, is characterized by prolonged helplessness and discouragement about the future. Individuals with this disorder have low self-esteem and very powerful feelings of worthlessness. They also lack the energy to do the things that they used to enjoy, much less the things that they have to do or the things that they don't enjoy. They tend to feel socially isolated and have trouble focusing on important tasks and have trouble making decisions. And this low mood tends to pervade all aspects of their life. There are a number of physical symptoms that also go along with depression. Lethargy, so feeling fatigued. Individuals with depression also tend to show fluctuations in weight, so either a lot of weight gain or a lot of weight loss. And they might also have trouble sleeping, or they might sleep too much. And I think that these physical symptoms are often ignored, because in Western cultures, like in the US, we tend to think about depression in terms of moods or in terms of emotional states. But for individuals in some Eastern cultures, especially cultures where it might be seen as inappropriate to delve into or talk about feelings and emotions, people in these cultures tend to think about depression and experience depression in terms of these bodily symptoms. And so it's really important that these aren't discounted. Depression or depressive symptoms are the number one reason people seek out mental health services. And because of this, some people have taken to calling it the common cold of psychological disorders. And I like that term for some reasons, and I dislike it for others. What I like about it is that it captures how pervasive this disorder is. It is estimated that 13% of men and 22% of women worldwide could meet the criteria for depression at least once in their lives. And one study has shown that as high as 31% of college students might experience this disorder. And these are really high numbers. And so in that way, I think that this term is appropriate. However, I think that the term common cold doesn't really capture the seriousness of this disorder, because depression isn't just feeling down once in a while, and it's not feeling sadness or grief at appropriate times, which is just a normal part of life. And I think that this term kind of minimizes that part of the disorder. Depression can be triggered by a life event, like a loss or a breakup, but it doesn't have to be. It also doesn't usually appear alone. It is actually really common for individuals with depression to have other disorders, such as anxiety disorders. And I've been writing in this blue color to kind of signify depression, but I'm kind of getting bored with it now, so let me switch it up. So there are a number of factors that may be involved in depression, and I'm going to split them up into 3 categories: biological factors, psychological factors, and sociocultural or environmental factors. And let me take a minute to get all of that down. All right. First of all, we know from family and twin studies that there's a genetic component to depression. We also know from studies that use functional imaging that individuals with depression show a decreased activation in the prefrontal cortex. And this could be associated with the problems with decision making that people with depression tend to have, as well as their difficulties in generating actions. Researchers have also found lower levels of activity in the reward circuitry in the brain. And this could help to explain why individuals with depression might not find enjoyment in the actions that they once found pleasurable. Depression has also been associated with certain neurotransmitters and neurotransmitter regulation. And I'll abbreviate that here by writing NT for neurotransmitter. Research has suggested that individuals with depression might have fewer receptors for serotonin and norepinephrine. And I think that all of this research is amazing. I think that it's really important. And it's also really compelling in a way that research findings that include neuroscience typically are. But with that said, I really want to caution you against oversimplifying these biological factors. To give an example of why I'm saying this, I'm going to talk about the relation gene and depression. And this gene is known as 5-HTT-LPR, and I'll write that down. And a lot of findings have shown that this gene is in depression. But in actuality, it is only associated with depression if the individual with the gene is in a stressful environment. But the story doesn't actually end there. It's actually even more complicated. Because it turns out that if an individual with this genetic feature is placed in a warm and positive environment, they actually show a decreased risk for depression. And this is something that we don't totally understand yet. We're still trying to figure out why this might be the case. But importantly, I think that this really shows us how complicated biological factors can be. Let's move on to some psychological factors that might influence depression. One theory is based on the concept of learned helplessness. And this theory supposes that if an individual is exposed to aversive situations over and over again, without any power to change or control them, they might begin to feel powerless in a way that might lead to depression. So if someone is exposed to prolonged stress due to family life or bullying or some other cause that they don't have control over, their helplessness could spiral out of control. And they might stop trying to change their situation because they perceive it to be completely helpless. And that's a behavioral theory or way of thinking about depression, but there are cognitive theories about it as well. And these theories tend to focus on thoughts or beliefs that, with repetition, could trigger depression. And while it's true that everyone has negative or self-destructive thoughts every once in a while, generally we are able to step back from them. And we're able to realize that what we're thinking isn't completely logical. But sometimes people can get trapped in these thought patterns, and they might put too much emphasis on negative thoughts and actions and experiences. And when they ruminate on these things, when they turn them over and over in their minds, it's possible that these cognitive distortions might lead to depression. Another cognitive theory about depression focuses on the concept of attribution or explanatory style. Now, as we go about our daily lives, we naturally try to understand and explain the events that go on around us. And when we do this, we can either attribute the things we see to internal or external causes. So is it something that I did, or is it something that happened because of something that is completely out of my control? Did I get a bad grade on a test because I didn't study? That would be an internal cause. Or did I get a bad grade because the teacher made a really unfair test, which would be an external cause? Individuals with depression tend to attribute negative experiences to internal causes. So maybe they'll think that a friend didn't call or text back because they are unlikable or unlovable, and not because they were at the movies with their family and maybe their phone was off. In addition to this, they tend to see negative experiences as being stable. So they think that they'll continue to happen in the future. And they also tend to think that they're global. So they might assume that one friend not calling them back somehow signifies that none of their friends like them. And together, these things, these internal attributions, these stable attributions, and global attributions, these things form a pessimistic attributional style. And it might make certain individuals particularly vulnerable to depression. And there are many other psychological theories about depression, things that have to do with coping style or self-esteem. But it can actually be hard to know whether these things cause depression or if they are the result of it. So does a pessimistic attributional style lead to depression, or do people with depression tend to have a pessimistic attributional style? It isn't always clear. Environmental and sociocultural factors can also have a strong influence on depression. Having a friend or partner or roommate with depression can actually increase the likelihood that individuals around them will also develop depression. And although we don't know exactly why that is, some researchers suggest that it might have to do with co-rumination, where friends talk about problems and negative events. But instead of discussing how to solve them, they focus on the negative emotions and dwell on future problems and occurrences. And on some level, this is kind of normal. It is perfectly normal for close friends to take on some of the negative feelings of the other, like being sad when they lose someone who was close to them, or being angry if they were dumped by their partner. This is just natural empathy. But the same empathy that allows us to comfort our friends when they're in distress might also be the reason that depression seems to spread. We also know that individuals with a low socioeconomic status, especially those living in poverty, are more likely to develop depression, as are those who are struggling to keep a job or have just lost a job. And there are other environmental factors as well. Social isolation, child abuse, even prejudice have all been implicated in causing depression. And let's think about this in terms of prejudice. If someone grows up in a household that has negative feelings about homosexuality, and if they grow up and begin to have same-sex attractions, they've probably internalized the prejudice after years of hearing it, and this could lead to depression. All right, so stepping back for a second, we said that we had biological factors, psychological factors, and sociocultural and environmental factors. And when we put all of these things together, we get what is referred to as a biopsychosocial model of depression. And this theory acknowledges that all of these factors play a role. So some people are genetically predisposed to the condition, but it only comes about if the situation is right, or if we develop certain patterns of thinking.
All right, so Khan Academy, I like utilizing them for those parallels. Okay, bleeding control, I think I'll go over fairly quick and then we'll end our day. So we talked about trauma in class the other day, multi-system trauma and head and neck back trauma. So we're gonna go over bleeding and bleeding control. We need to be able to recognize bleeding, understand how bleeding affects the body, and then is it external or internal, and then or both. And bleeding can cause weakness, shock, and death as well. So recognition is important. Hemorrhage means bleeding. Examples, nosebleeds or bleeding from open wounds. As an EMT, we need to know how to control external bleeding and recognize internal bleeding. So the significance of external bleeding may be difficult to tell the amount of blood loss. I had touched on the other day about what surface they're laying on, right? So if they're laying on snow and bleeding, how it can just kind of go straight down and you don't really see that pooling like you would like on concrete or something. Presentation and assessment of the patient will direct care and treatment. And then knowing that your body will not tolerate a blood loss greater than 20% of its blood volume until you cannot compensate for the blood loss any longer. Significant vital sign changes may occur if the typical adult loses more than 1 liter of blood. So we talked about donating blood, right? Which is 500 milliliters, so about half of that. So if you lose a liter or more, you get an increased heart rate, increased respiratory rate, and a decrease in blood pressure, because that's your body trying to compensate for any of that blood loss, right? So an adult can comfortably donate 1 unit, so that 500 milliliters of blood over 15 to 20 minutes. If similar blood loss occurs in a much shorter amount of time, they can go into hypovolemic shock. And if they have pre-existing health conditions or whatever, can play into that. Serious conditions with bleeding, so a significant mechanism of injury. If the patient has a poor general appearance and is calm, right, we're thinking shock. Signs and symptoms of shock: pale, cold to the touch, sweaty, right, cold sweats, cyanotic, any of those. Significant blood loss, rapid blood loss, or uncontrollable bleeding. If they have an arterial bleed, it's under pressure, so pressure causes the blood to spurt, making that bleed difficult to control because it is under pressure. Typically brighter red and spurts with each pulse. We saw in that video where the nail was taken out of the hand, how it kind of just spurted. That's arterial, that's under pressure. Versus venous bleeding, which would be a dark red, flows slowly, but can be severe. But because it doesn't spurt, it's mostly easier to manage with pressure. And then capillary bleeding, so damaged capillary vessels, so more towards the surface. So like when you cut your finger. It's dark red, oozes steadily but slowly. So capillary bleeding like on the finger, venous bleeding like on the knee there, and then arterial spurting right of the wrist. Clotting, bleeding tends to stop rather quickly within about 10 minutes or so. When a person is cut, blood flows rapidly. The cut end of the vessel begins to narrow, reducing the amount of bleeding. And then when a clot forms, bleeding will not stop if the clot doesn't form. So that's why we're aware of patients being on blood thinners or even aspirin, because it's a platelet aggregate that doesn't let clots develop. Despite the efficiency of the system, it may fail in certain situations. So any movement, or if the injury is at any sort of joint, right, with that movement, it's a lot harder to clot. If they're on any blood clot medications, removal of bandages, which could tear off a clot or a scab. External environment, if it's a hot environment, clotting is harder. If it's colder environment, clotting is easier. Right, body temperature, same thing, and then how severe that injury is. We talked about bleeding disorders like hemophilia. If they lack the clotting factors, then they're not going to clot, and it's going to be really hard to control that bleeding. Internal bleeding, so bleeding into a cavity or space inside of the body, can be serious. usually no outward signs, which is very hard to tell, especially abdominal bleeding, because you have such a massive area that can collect blood and can pool a large amount of blood before we even see any signs of that blood loss. So internal bleeding can vary from small bleeds like bleeding ulcers to ruptured organs like ruptured spleens, but all considered internal bleeding, just at different severities. MOI for internal bleeding, high energy impacts, right? Mechanisms of injury like car accidents. Internal bleeding is possible when the MOI suggests severe forces, so blunt force trauma or penetrating trauma. Bleeding is not always caused by the trauma. You can have non-traumatic causes. So, for example, bleeding ulcers, bleeding from your GI tract, ectopic pregnancies, or aneurysms can be non or atraumatic. Frequent signs, abdominal tenderness, guarding rigidity, pain, and distension. So that's why we're feeling the abdomen in all 4 quadrants for any of these signs. In older patients, some signs could be dizziness, faintness, and weakness, because they're going to be, they're not going to compensate as well as a healthy adult with blood loss. So you might have dizziness or weakness. Ulcers or GI problems with bleeds may cause vomiting or bloody diarrhea or urine, kind of depending on where that bleed is. If it's a higher bleed or lower bleed, you're going to get different characteristics of how that blood looks. Signs and symptoms of internal bleeding: pain, swelling, distension, bruising, dyspnea, so trouble breathing, tachycardia, high pulse, and hypotension, low blood pressure. Could potentially be a hematoma, so a pocket of blood, right? So could be a hematoma on the brain, could be a hematoma really anywhere on the body, but collection of blood, right? And then any external bleeding from body openings. Hematemesis is blood in the vomit, right? Emesis is throw up, and then anything hema is blood. Melena is bloody stool. Hemoptysis is coughing up of blood, so kind of like that frothy, foamy, pink tinge to the sputum. Broken ribs and bruises, rigid or distended abdomen should all kind of clue you in internal bleeding. And then hypoperfusion, so they're not perfusing for some reason. If they're not externally bleeding and they're shocky or whatever, we're thinking about internal bleeding. And then later signs, so tachycardia, weakness, fatigue, dizziness, thirst, nausea, vomiting, shocky symptoms, right? Cold, moist, clammy skin, shallow, rapid breathing. These are all signs and symptoms that are cluing you into shock, but as well as shock because of internal bleeding. Late signs: dull eyes, slightly dilated pupils, cap refill is longer and longer, weak, rapid, thready pulse, decreasing blood pressure. So these late signs, remember, we can compensate up until that tipping point, and now we're decompensating pretty rapidly. So we're checking all of our anatomic regions on our secondary. So we're checking the head for raccoon eyes. Remember that the bruising look around the eyes, battle signs, the bruising behind the ears, any drainage from the ears, eyes, or nose. Eyes, not really, but feeling all 4 quadrants of the abdomen, and then getting vitals. Vitals may change throughout your treatment. So if you stop that external bleeding, then your vitals can kind of level out instead of kind of stay on that decline. Any blood pressure less than 100 millimeters of mercury systolic is hypoperfusion, so they're not doing great. Reassessment every 5 minutes. Don't delay transport. External bleeding. So direct even pressure with elevation is going to be your first go-to with any external bleeding. Pressure dressings and or splints, and then tourniquets if the above mentioned are not working. It'll often be useful to combine some of these methods. So direct even pressure and pressure dressings are usually all it takes. If it's an arterial bleed, you're going to need a tourniquet and then a pressure dressing as well. So direct pressure is going to be the most effective way unless it's arterial. Pressure that stops the blood flow and lets coagulation and clotting start. So make sure you're wearing gloves, apply sterile dressings, press hard, and for a good period of time. If we have impaled objects, we're not removing them. We had talked about that already. We're just stabilizing them so they don't move. We want to hold uninterrupted pressure for at least 5 minutes. Elevation will help while applying direct pressure because remember gravity. So if you elevate the body part above the heart or if they lay down, you don't have that pressure that's moving against gravity. But we never want to elevate an open fracture. Fractures can be elevated after they're stabilized and splinted, but not beforehand. And splinting and keeping that extremity in alignment and in what it's supposed to be natural anatomic alignment will help with that bleeding as well. Pressure dressings, so wrapping a sterile self-adhesive roller bandage around the entire wound, cover above and below the wound and stretch the bandage tight enough to control the bleeding. We don't want to stretch it tight enough to make it a tourniquet, so we still want to have a distal pulse behind it, but enough pressure to keep that to help clot and stop that bleeding. Whenever you put dressings on and have controlled that bleeding and put a pressure dressing, we don't want to remove that dressing because we did promote clotting. And if we take it off to look at it, we could peel back that scab and have it bleed again. So once you have it pressure on it, it dressed up, we don't take it off to look at it. If it does keep bleeding through the bandages that you've done and the pressure's not working, then we need to just jump straight to a tourniquet and not mess with redoing the bandaging and all that. If they're bleeding out, we need to control it. So if direct pressure fails, we're applying a tourniquet above the level of bleeding, should be applied quickly and not released until at the hospital. We don't want to put tourniquets over joints because of the movement, and you're not going to get good compression over a joint because of the bend, as well as where the arteries and veins kind of bury in between the joint and come back out for the long bones. You're not going to get good compression of the arteries and veins at a joint. Never use wire, rope, belt, or any other narrow material. If you use narrow material, it just cuts into the skin instead of putting pressure to stop the blood flow. So you're just going to create more damage. So we, as EMS, uses commercially made tourniquets. But also knowing that we can utilize different materials to make our own tourniquets. If we don't have our tourniquets, which with responding agencies you will, but backcountry type stuff. Triangle bandages are utilized a lot in first aid to be able to build your own tourniquet. So you wrap it around, tie a knot around a stick or a rigid object and twist and then secure it down for the bleeding to stop. I usually go with the military regulations for tourniquets, high and tight. So high up, like under the armpit, or high up onto the groin. You can apply, I think it's like 2 to 3 inches above the wound, but usually you kind of get close to a joint there. So high and tight is usually where it's at. A lot of people used to be scared to use tourniquets because they said life or limb, right? And these days, and I think because of technology and surgery and things of that nature that we've actually been able to successfully have tourniquets on up to 6 hours or more without any major deficit to the affected limb. So when in doubt, put that tourniquet on. And surgeons are doing amazing things these days. So bleeding from nose, ears, and mouth, skull fractures, facial injuries, infections, high blood pressure can all cause this. Epistaxis, which is a nosebleed, is a common emergency. Can occasionally have enough blood loss to be an emergency and send our patient into shock. For whatever reason, it's been uncontrollable, but can usually be controlled by pinching the nose together up at the bridge. Ice packs help slow that bleeding down as well. A lot of the teaching now is to pinch and have the head face down instead of tilt back up, because just have the bleeding coming out instead of down towards the back of their throat. Bleeding from nose or ears might clue you into a head injury. So it may indicate that skull fracture. That's why we're looking for the raccoon eyes or the battle signs, right? Those are indications of a basilar skull fracture. Might be difficult to control if they're bleeding through the ears or nose from not direct trauma, right? Direct punch or blow to the nose. If they're bleeding despite that, we don't really want to stop that flow and clog it up because of intracranial pressure, but we'll kind of loosely cover with gauze to try to slow it down or collect it. But there's not a whole lot we can do except transport. Internal bleeding, surgery is going to be a requirement. There's not much we're going to be able to do except recognition and transport. If they don't have a spinal injury that you suspect, put them in that shock position, give them high flow O2 and transport. Keep them warm, maintain their body temperature. If they have broken extremities, right, splinting them, could be an air splint, could be a rigid splint, could be a traction splint. We'll go over splinting on a different day. Never use a tourniquet to control internal bleeding, because you can cause compartment syndrome and overpressurization of that limb, and it does a lot more harm than good. Okay, I think I have, where am I? Okay, I told you guys that I was going to show you the HALO test for CSF. So HALO test is when there's suspected cerebrospinal fluid with blood mixed in, to kind of tell if there is anything more than blood. It's called this HALO test. So a drop of blood and you can kind of see this clear fluid that seeps beyond the blood spot, and that's a positive HALO test sign, and that's positive for cerebrospinal fluid. And sometimes you can see it without even meaning to, and I've seen this on a patient before, of where the blood from the ears drip on the sheet, and it does the HALO test kind of for you, and clues you into CSF that's going on. So what other, there was another thing about bleeding that I wanted to show you. Oh, right. There's one more. I'll pull up, I have my saved Instagram for EMT class. Let's see. Saved. Well, that's an interesting one. So tourniquets, these are improvised tourniquets, but utilized nonetheless. Another tourniquet utilization. Looking for my blood loss ones. There he is.
Thick water, so it's not going to look exactly the way you want it here to simulate it. But if you came into a room and you saw all this on the ground, you'd be like, holy fuck, that's a lot of blood, right? It's like, dude, what the fuck? How much blood do you get when you donate blood? About a pint, right? What do they give you when you donate blood? Cookies, a little bit of juice, right? And you feel a little euphoric after you're done with it, right? So you're like, all right. But that's how much blood you donated. And you're still in the fight, right? Now, you're still pumping out. Now, I haven't even tried to mitigate this yet. All of this goes on the ground. Holy shit time. Are we? Is this bad? Yes, it's bad. From the standpoint is water, obviously. Blood is thick.
So I like this guy, and this is just a part of his clip. But he's showing, so those smart water bottles are a liter. And so the example there's 5 liters of blood in your body. And so his example is if you lose half of that, right, it's the same as donating blood. And then if you lose that whole liter, that's when your body starts going into that compensation mode. And once you lose past that, then you start to decompensate because your body can't maintain after 20% blood loss. So I like this guy and how he represents that in a visual. And even though showing kind of on the ground, it looks like a lot more blood than we realize what it is. So it is kind of hard to tell an estimation of blood loss. But that's kind of a good example that I like utilizing. Okay, that is all I have for today. I will email you guys with a new permanent link for class. This one was just kind of a temporary one that I threw out. Thanks again for being flexible. So look for that email from me for Wednesday. But other than that, have a good night, and I'll see you virtually on Wednesday.
Thanks, Emery.